universities are fighting with each other anyway. When they both will come into synchrony, we have no idea. But a beginning has to be done somewhere.
No, definitely university or some other bodies recognition is one of the important aspect, but still the subject is evolution. And we don't have any definitive, these things who can do and who can't do. But two very important aspects. One is your explain the patient what you are going to do. That is very important. What might be the possible complications. And second thing is sticking to the evidence-based guidelines. So if we are having, if you can support that, okay, these are evidence, such and such societies recommend these procedures to do. So we are little bit, not a complete safeguard, but little bit of safer side. But this has been done, this has been recommended by such and such societies to do this procedure. So there are basically two things. One is either let us create some evidence, or we should follow the evidence-based guidelines.
I would like to mention here, what Dr. Dureja mentioned. Speak to the patient, establish a rapport there, so that the patient also, of course patients are unreliable, they can turn back on you anytime, but the chances of them turning back on you are a lot less if you communicate with them in an honest and frank manner.
We'll just wrap up with one last point by Dr. Harshay.
With due respect, what Arif said, let us understand the basic scenario. In America, the patients are not paying. It is the insurance company which is paying. Now, if I am an insurance company, I have to send a patient to a pain management who is going to charge $2,000, and a surgeon who is going to charge $20,000. What I would feel is, let me route my patient through pain management so that 70% patients are screened, so they automatically get the patient. They don't have to practice hard. Here, every patient is a bearer check. If I am an orthopedic surgeon, to be very honest, why I will refer my input to somebody else? So while we say that they don't refer, let us understand the fact that if you want patient, you have to market yourself directly to the people who are in plenty. And they go for all nonsense things, like they go to quacks. We call it, हमारे लात मारवाने जाते हैं. अगर patient वहाँ जा सकता है, तो patient will come to you, but he should know that you do this, right? So that's the only way.
The last comment based on this, that you have to educate the public. They are the ones who will force the doctor to send them. So that is what is really helping me. Once you are advertising and telling people what is epidural, they are telling the surgeon, why can't you refer me for an epidural? So this is how you do.
So thanks. Now everyone's getting lively. So we'll just go on to the next speaker and start off. So I'll ask our chairperson to introduce the next speaker. The only word of introduction that I have for her is a phenomenal person. I think I've worked with her. I've grown up being a pain physician in her arms, literally. She's like mom. So I'll just ask Dr. Sarusin to introduce Dr. Lakshmi Mas.
Dr. Mahesh is quite right. Dr. Lakshmi Mas is the lighthouse of all the physicians who want to set up an ideal pain clinic. I invite ma'am to enlighten us on the topic.
Anybody around here to? I have to put my presentation up, so please give me some time. Thank you very much for the introduction. So, what is ideal pain management? There are several standards: ideal, optimal, feasible, possible, etc. So, let us look at the ideal. And WHO recommends a biopsychosocial model: bio-bodily pain, psycho-mental suffering, social return of the patient to his prior lifestyle in society. This is the most difficult goal actually. You can catch hold of this and you can remedy this. But this is where all our maramari, as I would say, goes on. Interventions form a very small part of the ideal pain management. In not be technicians. If you are an interventionalist, you are only a technician and you are certainly not a pain physician. And I think Dr. Tureja has spoken enough about that, so I will not go ahead more on that. So in 1931, Albert Schweitzer wrote, pain is a more terrible lord of mankind than even death itself. So, treatment of pain, we are very privileged people. You see, we could have been anything as doctors, but to be a pain specialist, pain management or consultant, I think is the greatest privilege that we can have, and we should respect this and utilize it. And he also said that we must all die, but that I can save him from days of torture, that I feel is my great and ever new privilege. How many doctors can boast of this kind of work atmosphere? So let's come to an ideal pain clinic. You need a pain physician, pain nurse, well-trained staff. And a very important part is an in-house physiotherapist who is in sync with you, who knows what you are doing and you know what they are doing. Then in India, I think a yoga teacher, even if you had a part-time person to guide your patients, nothing like it. I'll tell you why later. Access to a psychiatrist, a clinical psychologist, a dietitian. And we need to have a networking with other specialists like neurologists, orthopedic surgeons, spine surgeon, hand surgeon, rheumatologist. All these are people with whom you will save their lives most of the time, and they will save your life once in a while. So, in-house physiotherapists, before the emergence of pain as a specialty, or physiotherapists were the pain specialists. PT produces fairly good results in mild pains. So, that is where their idea of success comes in. Improves moderate pains to a good extent, probably. But in severe pains, improvement is negligible or temporary. And this is the kind of patients who get referred to us. So, however, once conjunction with pain interventions or pain management techniques, PT makes a major difference. But bottom line, pain physicians cannot do without physiotherapists. Yoga teacher, yogasanas are very effective in back, pelvic and shoulder issues. They are a very subtle but very powerful way of simultaneous stretching and strengthening. If you were to compare yoga with physiotherapy, yoga is like an ancient wise old man, and physiotherapy, the best of physiotherapy today, is like a braggart toddler. So this is the best example I can give you of the comparison. However, yoga is very complex and requires expert supervision. Usually, I like to say, yoga ka aisa hai, kahi pe nigah hai, kahi pe nishana. What the asana will do to which part of the body you won't know. So they need to be guided slowly by a proper teacher. And there are certain things called mudras, where the pose is held for a little while. And these are very, very, very useful. I cannot tell you how useful it is in headache pains, trigeminal neuralgias, migraine, etc. They are invaluable, very effective. And certain practices like Shadhanana Mudra, etc. are extremely useful in calming the mind. We are after all doing the biopsychosocial model. Pranayamic practices also. Prana means breath, ayama means manipulation of. There appears to be a direct connection between breath and the mind, and there is an expressway between mind and muscles of the body. Muscles could well be the final common expressor for every single pain that there is in chronic pain medicine. Hence, if patients could be taught pranayama in conjunction with effective pain management, anxiety and catastrophization could be reduced as well as pain. Acupuncture is another very, very useful thing, but I don't use acupuncture for usual chronic pain management because the results are temporary. I'm a trained acupuncturist, but I don't use it at all in pain management, except for migraine. These points are called Jingwell points. They're very effective in when a patient comes literally reeling with pain. If you put these points, they come down in pain and then we can talk. So, access to psychiatrists, clinical psychologists, There are red flags like suicidal ideations, but many others come with lesser problems, anxiety and depression. You need to assess it, you need to quantify it with a validated scale so that you can see the improvement later. Usually, primary cause, many times other doctors say pain is in the head. I really dislike such doctors who say pain is in the head. It is not what is in the patient's head, but what is not in the doctor's head. After 12 years of pain management, I can very confidently say that the number of patients who imagine their pains is not even 5%. Everywhere, pain is the general cause of the problem of psychological disturbances. And the disability, a disabled person has no self-esteem. If you and I got disabled, we would be as psychologically involved as the patient. So an effective pain management could be the key to reducing the psychological ramifications of pain. But as I said, GAD, there is a general anxiety disorder scale and patient health questionnaire. So this one assesses depression, the other assesses anxiety. So now here, last week I got this girl, young girl of I think 17, 18 years. She came with foot drop, pain in the leg and an X-ray like this. Note this, lytic area. She was under the care of an orthopedic surgeon who had said that this X-ray is okay, no problem, just wait and watch. With the foot drop, he's telling her to wait and watch. So I sent her to an orthopedic surgeon and it was found that she had osteosarcoma. So you should know when to refer. These are patients, there are some patients who come to you first. So that is a dangerous situation because you are not the expert in that field. So you should have a friend who can bail you out in such things. Then there are some patients who come with very weird neurological problems. I had a patient who came with Parkinsonism and she would say she did very well with the pain management, but she would say, I can't stand, I can't walk. I didn't know what this problem was. I sent her back to the neurologist. Neurologist simply adjusts the Parkinsonism medicine and sends her off. So I said, no, I want a second opinion in neurology. There is something problem here. And then it was found that she was having a disease called multisystem atrophy, MSA. So that's a very serious condition. And Parkinsonism is one of the symptoms of that condition. So you should know who can bail you out when. Scaphoid fracture is notorious for being missed by everybody. If a patient comes first to you, you should know when to refer to a hand surgeon. So pain management itself, let me come to. So, I started 12 years ago. I'm a rather late entrant into pain management as compared to Dr. Dureja and many others. One fine day I decided enough of anesthesia and I jumped into pain. That it is said that fools rush where angels fear to tread. I'm the quintessential fool.